Good evening, everyone, and welcome to the GP Lens Institute's monthly educational webinar. My name is Ed Bennett, and I'm the Executive Director of the GPLI. As you know, the GP Lens Institute is the educational division of the Contact Lens Manufacturers Association, those independent laboratories and button manufacturers who are responsible for the high-quality GP and custom soft lenses we see on the market today. The most important topic in contact lenses today is myopia. And more specifically, can we slow myopia progression and how should we approach it? Of course, since the early 1960s, we've had a tool in our toolbox that has demonstrated a significant slowing of myopia progression in addition to allowing the wearer freedom from vision correction during the day. Of course, that modality is overnight orthokeratology. Our speaker tonight is very well qualified to address this topic. She's the owner of Alamo Eye Care in San Antonio, where she's the director of the Contact Lens Institute of San Antonio. She is, in addition to all this, she has expertise not only in orthokeratology, but managing very complex corneal and anterior segment cases with specially rigid gas permeable and soft lenses, such as keratoconus, keratoplasty, pediatric and adult aphakia, trauma, and graft versus host disease. She's a graduate of the University of Houston College of Optometry and later completed a cornea and contact lens residency at the University of Houston. She's a fellow of the Scleral Lens Education Society, advisory board member of the GP Lens Institute, and she is both a fellow and a diplomate of the Cornea, Contact Lens, and Refractive Technology section of the American Academy of Optometry. Speaking on the topic of overnight orthokeratology today, please welcome Dr. Melanie Fregoso.
Thank you, Ed, for that introduction. And thank you, everyone, for taking the time out of your busy schedule to spend with us today. I am really, really excited about sharing this information with you about orthokeratology. But before we get started, I'd like to go ahead and give a very special thank you to Patrick Caroline, Craig Norman, Jaume Pan, Mark Cosgrove, and Thomas Wyszewski for allowing me to learn from them and providing information for the presentation I'm about to share with you. Before we get started, I'd like to go ahead and get some housekeeping out of the way. These are my financial disclosures, and I'm really excited about speaking to you on this topic. Like Ed said, my training originally is in irregular cornea, and during my cornea and contact lens residency, this is what I concentrated on. So I fitted mostly keratoconic patients and high refractive error. And then when I went on to do my fellowship at the University of Iowa hospitals and clinics, I learned more about irregular cornea and complex anterior segment disease, and I had the opportunity to also work with infants and then also manage from infants to age 100. It's when I opened my practice in San Antonio, when I came back home to Texas, I started seeing patients, and then I got these referrals for myopia control and myopia management for patients who are myopic, and they're for orthokeratology. I did some orthokeratology during my residency, but it's something that I didn't really concentrate on. So I was really interested in doing this because I love a challenge. And since I've started this, I've never looked back. It's a very rewarding patient base. It is challenging, but once you get started and you delve in, it's very interesting and professionally rewarding. I think to really, before we learn about what's going on in orthokeratology today, I think it's important to understand the definition and the history. So orthokeratology is a clinical technique which uses specifically designed and fitted rigid lenses to reshape the corneal contour to temporarily modify or eliminate refractive error. It's also known as ortho-K, OK, CRT, VST, corneal reshaping. All of this is referred to as orthokeratology. So the history of orthokeratology, I think, is very interesting. Where we think it came from is there are some unconfirmed stories that ancient Chinese actually slept with tiny little weighted sandbags on top of their corneas in order to flatten their corneal curvature and reduce myopia. In 1888, Eugene Kalt then had the idea for flattening keratoconus corneas using glass scleral contact lenses. And then in the 1950s, it wasn't until the advent of corneal GP PMMA lenses, practitioners started to notice changes in refractive error in patients who were myopic, and in lenses that were fitted slightly flatter, they noticed a reduction in myopia. So it wasn't until 1962 that I think orthokeratology first became recognized. This was when George Jessen gave a lecture to the International Congress for Contact Lenses in Chicago. He gave a lecture about his theory, his technique that he was using on his patients called orthofocus. And this is where he actually fitted myopes in plano PMMA corneal lenses of conventional shape, lenses that were steeper in the middle and then progressed flatter into the periphery. And he fitted these lenses flatter than the amount of myopia that needed to be corrected, flatter than their keratometry reading, and then by the amount of myopia that needed to be corrected. What he intended was for his patients to wear these lenses during the day, and then a few hours before they went to bed, they would remove them and have uncorrected, undisturbed vision without glasses or contact lenses. So for the next 20 years, practitioners tried this. There were even some large studies that were done with orthokeratology, and they found at this point, the outcomes were a little bit variable, so it had become very popular. The first thing was that treatment took too long. Because the lenses didn't center well, a lot of the times the practitioners couldn't target the whole entire myopic correction, so instead of targeting, all 2 diopters and 3 diopters, they had to move very slowly and only fit half a diopter flatter at a time until they reached their endpoint. And a lot of the times their endpoint was variable and unpredictable, and they didn't get a lot of myopic correction. And at the time, orthokeratology, the hope was that they were looking for something that was going to permanently alter the vision, and they found that this was temporary, which I think now is a good thing. And they also found that there was an induction with the rule and also irregular astigmatism. But the good news is they found that orthokeratology in general was safe and there were no adverse effects. So now let's jump into what orthokeratology is today. In my opinion, these five things that I'm about to talk about are what constitutes orthokeratology as we know it now, and why it's so popular. What made it become really popular is the advent in the late 1980s and early 1990s of high decay materials that made it, when we came out with these materials, they found the benefits of overnight reshaping. And then reverse geometry lens designs. These are designs where it's flatter in the middle, and in the periphery it actually steepens, and then it flattens out again. And what this did was it actually created centration of the lens and created the fluid forces underneath it in order to accelerate and treat myopia more efficaciously. And next is computerized topography. This now allows us to understand what's happening to the cornea, and then also allows us to design lenses better and understand how we can modify lenses if we need to, modify a treatment. Also, about the same time is computerized lathes. Now we have the ability to create lenses within a precision of 0.001%, or probably even more precise than that. And so this is amazing. And now we can create these orthokeratology lenses with complete reproducibility and very, very precise lenses. And now we have all this knowledge of the corneal physiology, and we have the tools to be able to understand what's happening underneath the lens. So now there's lots of different lens designs available in orthokeratology. It started off with just myopia, and still the most common clinical design right now is for the reduction of myopia. But now we have lenses that can correct for astigmatism, hyperopia, presbyopia, and even in some cases after LASIK refractive surgery. So next, I want to go ahead and talk about the safety and efficacy of overnight orthokeratology. In the late 1990s and the early 2000s, there was some media concerning orthokeratology and its safety. Unfortunately, there were some children in Asia who got microbial keratitis infections, and this was publicized in the media. And this was thought there's a fair number that were reported in the literature, but at the time in China, orthokeratology was not well regulated. The government did not have any regulations. There were untrained providers that were fitting the lenses. They didn't know where the lenses were coming from. There was poor hygiene, and this is probably where most of these problems occurred from. What's interesting is that orthokeratology is actually, when we actually looked at it, there's really no greater risk in comparison to other overnight modalities. And the risk for orthokeratology is probably the same as overnight silicone hydrogel wearers that we have today. So this is safe. However, if a patient is going to have microbial keratitis, the ones reported most in the literature are Pseudomonas and acanthamoeba. So if you have a patient that you suspect that might have a microbial infection, suspect these two organisms, and they need prompt care. Since then, there have been many studies that have shown that orthokeratology is safe and it works, and it works well in children. So don't be afraid to prescribe this modality. It's safe, and later on I'll talk about the benefits and how it can help patients retard myopia and for myopia management. The largest complications actually with overnight orthokeratology, the most common ones are central corneal staining or corneal staining in general, and lens adherence. So these can be easily fixed with just modifications in lens design. So how does orthokeratology work? Orthokeratology, I'm talking about myopic orthokeratology in this case, but the way that it works is that we fit this gas permeable rigid lens over the cornea, and centrally it actually doesn't bear on the cornea. There's actually clearance about 5 to 10 microns, and this actually creates a positive force that works against the negative force in the area of the reverse curve. That area of the reverse curve creates this negative suction, which works with this positive suction to then manipulate the corneal tissue to change the shape. And this works best if the periphery of the lens is sealed off and aligned with the peripheral cornea. So what happens to the cornea during orthokeratology? I think to understand this, we have to look back at our corneal histology. So just a reminder, the human epithelium is about 50 microns thick. There are several layers at the top. It's connected by tight junctions, which protect it from the environment. And at the bottom, between the cells, they are actually connected by gap junctions where they can communicate and actually even exchange material. They're made mostly of water, and they have the refractive index approximately the same as water. So in some of the literature, or a lot of the early literature, they said, where do these refractive changes come from? Are they from the epithelium only? So if you look at how thick the epithelium is, and if we use Monorlin's formula for ablation depth during refractive surgery, 7 to 8 microns thinning of that is approximately 1 diopter. And if everything was coming truly 100% from the epithelium, it's probably most likely you can't correct for more than 7 diopters of myopia. Now, the designs that are out today are the ones that are FDA approved here in the United States are up to 6 diopters of myopia. However, there are other designs that target higher cases of myopia, reports in the literature, minus 10 and higher. And this wouldn't be possible if, everything was coming from the epithelium. So just a review of some of the literature. This is a really interesting study put out by Chu and her colleagues in 2008, where they looked at cat epithelium, and they fitted orthokeratology lenses, both myopic and hyperopic correction, on cats, and they looked at what was happening at the epithelial level. And so here, the first picture to the left is the control. The middle part is where they would put the optic zone, and in the two pictures joining it are the reverse curve. So this is after 4 hours. Next to it, the picture to the right is 4 hours of myopic ortho-K wear. And you can see here is that the cells in the middle look a little bit compressed, and the periphery, they've kind of grown and look like they've changed their shape a little bit. We know that there's probably not any increase in cell increase in cells growth. Cell mitosis in this short amount of time. So maybe there's some intracellular fluid exchange between these cells, because that's kind of what it looks like. And then this is after 8 hours, where you can see these cells have changed even more shape. And then in 14 days, where they kind of reduced the size in the periphery, the reverse curve. In the middle, they've definitely thinned, but it looks like there may be even more of them. So the conclusions in this study is what they think is going on, at least in the epithelium during early stages, is probably cellular compression. So a change, there's not actually cells moving out of the center, but what's happening is that they think that the cells are actually compressing, and the intracellular fluid is exiting those gap junctions and entering into the reverse curve area. And in the late stages, they think there might be some epithelial hyperplasia, so increase in mitosis in the peripheral and in the reverse curve area, and maybe an increase in epithelial cell retention or decreased sloughing of the cells. So next, I want to go ahead and review a recent study by Kim and his colleagues put out in fall of 2018. And this is interesting because this is technology that we have now access you can have access to in your office of epithelial mapping. There is on OCT's software now that you can purchase to take epithelial maps. And what they did in this study is they took epithelial maps and then they subtracted it from the full pachymetry map. And from there, they looked at where, after myopic orthokeratology, what was thinning and what was thickening in both the epithelial and the stromal layers. And what they found was actually in agreement with older studies. They found that centrally and paracentral, and central was, I think, in the study they measured the middle 2 millimeters, and then from 2 millimeters to approximately 5 millimeters with paracentral. And in that area, they did see thinning, and then they saw mid-peripheral thickening, and mid-periphery in the study is where the reverse zone is. And then the stroma, they actually saw mid-peripheral thickening. So what happens to the cornea during orthokeratology? Where do the refractive changes come from? It's probably multifactorial. It's probably a combination between epithelial and stromal changes. It probably comes from, epithelial compression, epithelial hypoplasia, increased epithelial cell retention, and decreased locking, and stromal remodeling. So next, I want to go ahead and talk about contemporary orthokeratology lens design, the way the back surface of this lens looks like. And I'm going to concentrate here on the myopic lens design. So the first central portion of the back surface of the lens is the base curve radius. The second adjacent to it is the reverse curve. The relief curve, this is not present in all designs, but it is adjacent to the reverse curve. And then that joins with the alignment curve, which aligns the periphery. And there's a secondary curve, which aligns the peripheral curve to allow more fluid exchange. And the secondary curve is not in all lens designs. To the right, we have a photo of what the back surface of the lens looks like and how it would align to the cornea. Below this I think it looks like cat ears to me. It's actually what the tear layer looks like after treatment. So the first zone I want to talk about is the base curve zone, or the back optic zone radius. This is usually 5 to 6.5 millimeters wide, and it's what creates the treatment zone on the cornea. And the way that we calculate this is determined by the amount of corneal flattening needed, and it's determined by the corneal curvature, the flat corneal curvature, and the amount of myopia treatment that we're trying to aim, the target treatment. Under this base curve area, what you want to see or what you want to shoot for is 5 to 10 microns of clearance. This curve is typically spherical, but there are some aspheric designs, and the benefits of having an aspheric design is actually pushing or manipulating the cells more into the reverse curve area, so that way you can go ahead and treat for higher zones, higher targets of myopia. So you can see here the top pictures of a spherical base curve, but when you add eccentricity, that actually decreases the size of the central zone, and then it ramps up quicker into the reverse zone. And so that allows a deeper reverse zone and allows more cell changes underneath to create that difference between the periphery and the center to treat for higher amounts of myopia. So how do we determine what the base curve is going to be? This is going to be a combination between how much myopia you're trying to target and something called the Justin factor. So what's the Justin factor? It's kind of a fudge factor that's built in. So for instance, if you're correcting for, maybe a moderate to, low high myope -5, they may start to regress. If you treat them for plano at around 3 o'clock or 4 o'clock, they might start to regress towards myopia. So instead of treating them for myopia, or plano, targeting them for plano, what you would target for is actually maybe +1, +150, so that at the end of the day, they're not myopic. The Justin factor can vary between lens design from half a diopter, and in some designs it can be as high as +3 diopters. So here's just a quick exercise on how we would calculate the base curve or the back optic zone radius. This is a pretend patient, 4450 by 4500 in Ks. They have a manifest refraction -350, -50 with the roll. And so what you would do, your target would be the spherical equivalent, and then we would add the Justin factor of a diopter and a quarter in this case. You add the two together, which is 5 diopters, and so you would do 5 diopters flatter than the flat K, which would bring us to 3950 for our base curve radius. So the next zone I want to go ahead and talk about is the reverse zone, and this zone is about 0.5 millimeter to 1 millimeter wide. It's typically a radius of curvature, however, it could be a spline or a tangent, and the depth increases as the correction for myopia increases. So for higher corrections of myopia, this tends to be deeper. And the purpose of this is to, when you manipulate this, is to raise and lower the clearance over the base curve, the area over the treatment zone. So here's an example of this again. Here's the tear film layer. It's cut in half, so half of the cat, just one cat ear here. So the very top picture is where it is fitted over the cornea, ideally 5 to 10 microns. But in the second picture right below it, the reverse curve is too steep, so it increased the clearance over the cornea. And this patient is going to have concerns with too much clearance. It's going to create a central island, so an area of uncorrected myopia. At the very bottom, the reverse curve is actually too flat, and this lowered down the clearance centrally, and now there's bearing in this area, which can cause lens decentration, but in some cases it can also cause epithelial staining, which can cause a false central island. So the next zone is the relief zone, and again, this is not present in all lens designs. If it is, it's about 0.5 millimeter wide, and underneath it, you're going to see 10, or you want ideally 10 to 20 microns of clearance. And what this does is it actually encourages proliferation of the epithelial cells from the alignment curve into the reverse curve. So this actually, in combination with an aspheric base curve, the relief curve then just allows the reverse curve to create more changes underneath this area to treat higher degrees of myopia. So next, I want to go ahead and spend some time on the alignment curve. I think that this is arguably the most important curve on the lens. In my opinion, it's the hardest to I think get right. At least it is for me, and when I was learning. This curve is about 0.5 millimeter to 1 millimeter wide. It can be spherical, it can have asphericity to it, or it can be a tangent. This actually controls lens centration, and so it makes the lens center well, which is very important in orthokeratology, and alignment is desired. What's really interesting about this curve is this is where the greatest amount of epithelial thinning occurs underneath. So this is actually just a histology section from the same study from Chu and her colleagues that Pat Caroline actually shared with me. And it wasn't published in the original study, but he was nice enough to share this with me, where it actually shows that most thinning occurs in the alignment curve, even more so than the central base curve. So the alignment zone, how is the shape determined? It's determined by the shape of the peripheral cornea along the flat meridian at around 8 to 9 millimeters or at the cornea, in the mid-periphery cornea. So this is determined and can be read off of topography from the eccentricity value. The E value is the rate of corneal flattening moving away from the central cornea. So for me, this was a really difficult concept when I was first learning about specialty lenses to grasp. So I want to spend a little bit of time on it because I think it's very important. So the eccentricity value of the sphere is 0, and in the average cornea, it's about 0.55. And the lower E value, the steeper the alignment curve is going to be, and the higher the E value, the flatter the alignment curve is going to be. And so the way that I think about this is with shape. So I look at a football versus a basketball. A basketball to me, more or less, is a perfect sphere. And this, if you look at it, you can see that it actually is deeper and it creates a higher sagittal depth, and in comparison to the football where it flattens out, faster, and it has actually a higher E value. And again, it's kind of, I feel like everything when I was in optometry school was always opposite. So how do I try to understand this better? I always look internally into what I already know to try to understand, designs better. And this is really interesting. This software is actually from a scleral lens software that I use quite often in my practice. And I said, oh my gosh, this is a really good way to understand eccentricity. So this is a lens design cut a half section, and it's put on a number line, and above it is positive and below it is negative. So you can think about for something that has lower, or a shape that has lower, higher eccentricity, what this does is that if you push it above in the positive, this actually decreases the sagittal depth of the lens. And then it's opposite for something that has a decreased E value, is that you move towards the minus portion, and this actually lifts the lens up. So for me, this was a really good learning tool, and said, okay, this is eccentricity explained. So I hope that clarifies eccentricity a little bit for you. So last, I want to go ahead and review the secondary and the peripheral curve. What this creates is edge lift and tear exchange. The secondary curve is about 0.5 millimeter wide. 20 microns is ideal underneath it, and it presents a smooth transition into the last curve, which is also about 0.5 millimeter wide, and you want around 80 to 100 microns underneath this lens. So I want to break here to see if there's any questions that I can answer.
All right, very good, Melanie. We appreciate it. I'm going to mention a couple of comments. We're hoping to, in 2020, introduce some more orthokeratology resources. We think we certainly would like to do that. An FAQs module, we'd love to have. Still like to have a consumer brochure, base brochure. It's not easy because all methods of so-called myopia control really are not recognized by the FDA. So we have to be very, very careful how we approach that. But that said, we'd love to be able to do that as well. I also want to mention, I always mention who our advisory board members are who are online. And besides Dr. Fregoso, we have renowned orthokeratology specialist Bruce Williams on tonight, and really a very special person. One of the pioneers of modern orthokeratology, John Reinhardt's on tonight. And some of you will be familiar with his Reinhardt Reeves design because it was one of the first modern, innovative 4-zone orthokeratology designs. And he really was one of our true modern pioneers. And he reminded me that Stuart Grant just passed away. And when you're as old as I am, the first design that I remember in orthokeratology, dating back to the 60s and 70s, was the May Grant design. And Stuart Grant at one time was presented with the Global Specialty Lens Symposium Award of Excellence. So it is truly an orthokeratology evening. Um, I'm going to probably let you continue. Well, I don't think I see any questions coming in, so please proceed.
Sure. So orthokeratology today, ordering lenses is incredibly easy. Now you just pick up your phone and you can tell your consultant at the lab basic information, your manifest refraction, your horizontal visible iris diameter, and keratometry values. And they can create a lens for you. In some cases, some more values can be given in order to customize the lens a little bit more. In my personal practice, we have a high level of a high amount of Hispanic patients with astigmatism from limbus to limbus, and I've noticed that their E values are a lot higher in comparison to my Caucasian and Asian patients, which are less of my practice. And also is to consider for custom designs, maybe incorporating the apical radius of curvature, which is actually the apex power. It's the part of the cornea where power is most constant, has the most constant refractive power, and it's not always in the center. So these are two additional values that could be introduced for more custom designs. So I think corneal topography really does hallmark today's orthokeratology. I think it's really important to have because it allows you to analyze the corneal shape and create better lens designs for your patients. And I think it's 100% absolutely necessary for troubleshooting lens designs. If you are having a problem with a patient, you really have to understand what's happening underneath the lens and looking at the cornea. So I think that if you're going to practice modern orthokeratology, you really should have a corneal topography in your practice. So this is just the case that I want to share with you all, where I utilized corneal topography, and I thought it was really important to have in this case, and I was really thankful that I could look at this patient's corneal topography. So this is a 15-year-old Hispanic female. She came to me. She was already an established orthokeratology wearer. She wore her lenses for 4 years prior. She related glare and halos, and she came because the last practitioner that saw her said she needed to wash out of her lenses because of some corneal irritation. Her pre-treatment correction, she wasn't too sure what it was, but she thinks it was around a -5. And so here on the right, the right is that her corneal topographies that she had when she came in, and you could see here, the top one is the right eye, the bottom one is the left eye, but the lenses are decentering pretty bad towards the nose. But despite this, she could actually see pretty good. She was 20/30, and I thought, well, -5, 20/30, that's not, too bad of a prescription. That's not too bad for a visual outcome. That's not out of the realm. I wouldn't be able to tell if she didn't have any other concerns. I think, okay, this lens is fitting okay. If I didn't have her topographies, and she didn't come in with her lenses, so I didn't have the opportunity to look at them on eye. Her biomicroscopy, however, her lenses were creating this kind of odd peripheral corneal basement membrane changes, and it was more on the left eye versus the right eye. And so here to the right, I have a slit lamp photo that was taken by my past associate, who I think is on right now, Dr. Duck Tran. He's the new fellow at TCI Institute. And you can see these kind of weird, it's like this weird basement membrane change. It looked quiet. It didn't look like it was inflammatory. It didn't look infectious in any way. The eye was nice and quiet. So I said to the patient, you know what, I don't know what this is, but let's wash you out of your lenses completely. I can't promise we're going to do orthokeratology again. I'm going to put you on steroids and antibiotics 3 times a day for now. Let's go ahead and see you back, and we'll slowly taper, and let's just see what happens. So she was out of her lens for approximately a month, and her kind of corneal basement membrane thing disappeared after treatment, thankfully. And you can see here to the left, these are actually her washouts for after about a month, fairly normalized, more normal-ish eccentricity values, again, more with the rule looking cornea. So, and she was really anxious because she really loved her orthokeratology modality. She wanted to get back in her lenses. I did a refraction, and she's about a -6, and so that's actually pretty good if she started off as a -5. So there's probably some myop if she had, the normal progression rate of half a diopter a year, is that it actually retarded it a good, 50%. So what I thought was interesting is I actually took her topography when she first came to me, and then her topography that I did that day when she was, clear, and her cornea was more normalized. And I did a difference map, and you can see here, right eye on the top, left eye on the bottom, that her lenses were decentered, but there's also this weird area of central, like a central island. And I can't even believe, to me, this topography is an optical mess. I can't believe she could see 20/30. So this is just an example of, if you didn't have a topography, you have no idea what the patients are seeing through, is that she's complaining of glare halos. If this was me, I'm not even sure I could tolerate having, that much irregular astigmatism induced. So I then decided to refit her, and we fitted her in a lens that did incorporate her eccentricity values. This is actually, I think, 3-week treatment, and this is looking better. I know in orthokeratology, at least when I first started, I really concentrated on getting that bullseye, that round, reverse curve pattern, and that's what I really wanted to look at. And we see that here, but now I've learned to really look at the alignment curve and where that's applanating. If you can remember earlier, I said that's where most of the thinning is occurring. And so really what you want to see is not only that red ring, but you want to see a blue ring around it where the alignment curve is actually applanating, hopefully 360 degrees around with the peripheral cornea. And so you can see in this case in the right eye, is that the lens may be not applanating in the superior nasal region, and then the same in the left eye. However, she's really happy with this lens. She's like, these are great. This is much better than my last lens. I'm seeing 20/20 each eye, and the vision is really good. But I definitely know I wanted to improve the treatment because she wants this for myopia, myopia management. That's the reason why she got fitted in the first place. And so I wanted better centration of that defocus, that reverse curve pattern in her pupil. So I want to center the lenses better. And how do we do this? Here's these cat ears again that I think is a really good illustration to learn how to modify orthokeratology lenses. This is actually a cartoon that Thomas Waszewski shared with me during one of his lectures and allowed me to post on this lecture tonight, is that the cat ears is a tear lens that is created underneath the orthokeratology lens, and this is placed on the cornea. And here, if it's flat, what happens is there's good seal off on one side, and it kind of falls off the edge, and there's poor seal off on the other side, so it's not applanating. And that kind of seems like that's what's happening with my lens. And so what I did it steepened up the alignment curve. And I just dispensed that lens, I think, a week and a half ago. So I'm going to see her back, and hopefully we'll have better centration. And so I just want to share this case with you, because without this, if I didn't have a topography, I just maybe would have refitted her and then said, okay, well, you're 20/20, it must be fine. There's nothing else we can do for you. But here, what I can do with topography is that I can go ahead and tailor it to my patient, especially since she's a myopia management patient, is that I want to maximize the amount of retardation with the optics of the lenses and the molding process. So now I have corneal topography to help guide me do this, to help guide me through this. So next, I want to go ahead and talk about new lens designs. Before, limbus to limbus astigmatism was contraindicated, but now it's completely possible with the new lens designs, is that we can put toric alignment curves in order to correct for astigmatism, and in some cases, we can create oval optic zones and put toric back curves on the back surface of the lens in order to correct for higher amounts of astigmatism. So a study was put out by Randy Kojima and his colleagues, and he suggests that if you have more than 30 microns difference between the two major meridians, you should probably consider adding toric alignment curves in order to increase centration of the lens. So a good way to look at this on corneal topography is to put it on your elevation map, where it shows you the best fit sphere, and then you can go ahead and look at the two major meridians. Just put your scroller and see where that is micron-wise at about 4 millimeters out from geometric center. And if there is more than 30 micron difference, you should definitely consider doing a toric orthokeratology lens. So other lens designs out on the market, what's old is new again, is hyperopic orthokeratology. Historically, this came from noticing that GP aspheric multifocals, daytime wears, those with high amounts of eccentricity to correct for daytime presbyopic wear, the older designs created corneal molding, and it created, it created this myopic correction, but in hyperopes, what this does is it creates central steepening, and it corrects for hyperopia. So these lenses are 100% aspheric. What you look at when you look at these lenses is a little bit opposite than the myopic design, is that you actually have central clearance, mid-peripheral push, and then that reverse curve aligning it. So other new designs are presbyopic designs. The best candidates for this, in my opinion, are low myopes and low hyperopes with mild to moderate amounts of presbyopia. These designs actually look a lot like the myopic and the hyperopic designs that I just shared with you, but there's more advanced curves, aspheric curves within the lens itself. There are both center distance and center near designs in both hyperopia and myopia that are available on the market right now. So other new designs are post-LASIK designs. Best candidates are those if you have pre-treatment information. It's much easier to do. What you would do is you would use their pre-treatment Ks, their old refraction and the residual prescription that they have, and then just create a lens as if they've never had treatment before, and it works pretty well. If you don't have that information, I would try to screen and ask the patient if they can remember if they had, a high amount of myopia. If it's like some patients I have had refractive surgery and they were like -11, have gone through LASIK. Probably not the ideal candidate. Maybe a patient who was a -2 before LASIK surgery. Maybe those are I think those are your better candidates. If you have no information, what you want to try to do is get the back optic zone diameter approximately the same size as the treatment zone. And then that reverse curve, if you could get that over the area that was the treatment zone, or that higher zone on the steeper zone on the post-LASIK patients, what you want is you want to vault over that area and be as wide or maybe even a little bit larger by putting a relief curve an exterior curve on the back optic zone diameter in order to create that push to correct for the residual myopia in post-refractive patients. So in my opinion, orthokeratology today and in the future is in myopia management. And using orthokeratology as preventative care to decrease the ongoing and the creating now of the myopia epidemic. By 2050, half of the population in the world will be myopic. And right now, in our own backyard, a fair amount of our population in the United States, close to 50%, is already myopic. And in Asian countries, the prevalence is as high as 80%, with progression as high as 1 diopter per year in Asian children. And the earlier onset for myopia, the higher amounts of myopia they can progress to. And we know with the higher amounts of myopia they can progress to, it puts them at risk for sight-threatening disease. We know this myopic degenerative changes like glaucoma, macular degeneration, retinal detachment, early onset cataracts. All of these are at risk for patients in high myopia, and the higher the myopia, the higher the risk factors. So if we could go ahead and retard this, I mean, what a gift we can give our children. So the risk factors for myopia, you know, a while back we thought myopia was just congenital. It was if you had parents that were myopic, then the children was going to be myopic. But now we know that this is not necessarily the case, is that there's certainly, of course, a genetic role, but the environment probably has a huge role to play with this. Because we now see with increased urbanization that children are becoming more and more myopic and growing, their eyes are growing longer. I mean, this is a very good example when the doors opened in China, is that from 1983 to 2000, the increase of myopic children has increased by sevenfold, and this is when they started to urbanize. So myopia is a mix between both genetics and environmental factors. So those are things that we need to be talking about with our patients. So who are risky patients? Our Asian population, which we already talked about. Females, interestingly, actually progress more aggressively in comparison to females, and those that spend time indoors. Another reason why I'm so interested in orthokeratology and myopia management is because I myself am a high myope, and my daughter, who's 5, is also she's a refractive myope, and so I'm very interested in this, and this is why I'm very passionate about this subject. This is a picture of her. She's 5 now. This is when she was 14 months. So now we are so lucky because we live in a time where we have tools that we can use, myopia management tools. So what is myopia management? It's decreasing the progression of myopia progression, or preventing the onset. And we can do this now through orthokeratology. So orthokeratology retards the progression of myopia. And so this is just a cartoon example of what happens in a patient who is corrected with regular correction, both traditional spectacles or regular contact lenses. Centrally, it corrects for their myopia, but in the periphery, it creates a hyperopic defocus behind the retina, and that's thought to be a cue to continue axial length. Then in orthokeratology, what this does is it pulls that image cell forward, creates a myopic defocus in the periphery, corrects for the central myopia, but it then acts as a putative cue to slow down the progression of myopia. So, and this has been shown in studies in both high myopes and myopes, myopes who aren't high, is that it does slow down the axial length by about 50, close to 50%. So that's all I have for you. I think orthokeratology has a bright future. There's so many lens designs, lens modalities, and now with myopia management, I think we could really, really help our patients and help our children for a brighter future. Thank you so much for your time, and I'd like to open it now for any questions.
Okay. Well, a couple of questions that I have, and hopefully I've been able to answer them. Melanie, this was great, by the way. I do know one of the questions pertains to what design do you use, and I would recommend that person email you privately. I think
Sure.
that is the way we typically do things. Another question is one I believe is once you insert the lens, I always talk about lenses landing or the change in the uh, effective flattening that occurs early on. How long do you wait after you put the lens on before you assess with fluorescein?
Sure. Yeah. So I actually look at it right away. And then what I do is I have the lens settle. I have the patient sit in the room for 20 minutes with their eyes closed, hopefully most of the time. And then I look to see if there's any lens adherence. I take a look at the pattern. After 20 minutes, I take off the lens and I look at the corneal topography. And in a pretty good fit, I'm going to see changes of that reverse curve and that flattening. I would say I've seen it 100% of the time in a good fit. So I assess it, right away in the exam room. First one put on, and then after 20 minutes, I look at the lens.
Yeah, I have to take a minute and really compliment you. When I was coming out of school, orthokeratology didn't make sense to me because we were fitting rigid lenses, and I know John Reinhardt's on there and probably Bruce Williams both kind of nodding their head slightly, but they're rigid lenses, and you used one pair, and it took months for the process to work, and then you started having these innovative designs come out, and then you had the ability to assess with topography, which is, to me, I think essential with Ortho-K, and then the ability to wear them overnight and have the treatment effect occurring at that time. So we've just continued to see uh, the ability to more effectively and more predictably reduce myopia and also slow down progression. And as you show right on this slide, there's a bright future ahead. We need to clone you. I think the generation of the Bruce Williamses and the John Reinhardts, the people out there that have really started us and knew how important it is. We need to really clone more people like yourself, because, and that's a real compliment to you, because not enough people are integrating Ortho-K into their practice, and it is such a tremendous benefit. And you're impacting your associates, you're impacting students, you're impacting other professionals. So uh, kudos totally to you. Um, Let me see. There might be.
Thank
Oh,
you.
do you have any
Yeah.
Do you have any recommendations for textbooks on Ortho-K?
There's actually a good one that's put out that I own by the American Academy of Orthokeratology and Myopia Control. It's they sell it at their meeting. I don't even know if they have a web store online, but they sell it at their meeting. It's just a small textbook, and it gives an introduction to orthokeratology, and it talks about lens design. Whoever's interested, please email me, and I can go ahead and just screenshot a picture of it, and then maybe you can contact someone at the academy, and they can ship one to you. It's not expensive. I think it's like $30.
Good, good. And a couple more questions. There's always a question about safety. We've had a couple questions addressing it, because studies, it's just difficult to have studies that include enough patients to really get a feel for complications. And we were involved in the SMART study, and that had, I think, 8 sites, and the complication rate was very low. I know infections were extremely low. But I think Josephine's question is it really safe to wear a lens overnight? Are there risks? Of course, what we know is that the rate of microbial keratitis is the same as extended wear in general. That seems to have come out of 2 studies. So overall, I think the question would be that they are safe, especially since we know many of the ulcers have come out of Asia, or any area where there may not have been the education provided in terms of care and compliance and that we have today. But what are your thoughts on that, Melanie?
Right. So I agree with you. In the time that I've been practicing orthokeratology, I have some patients still wanting to sleep in their contact lenses, silicone hydrogel wearers, that still want to do that 30-day extended wear, and they won't take them out. And for sure, I have seen more complications, infiltrative inflammatory events from those patients than any of my ortho-K patients. So I think I would have to argue that I think ortho-K is safer, in my opinion, if you're doing everything correctly, right? If you understand the lens design, if you're manipulating the lens correctly and closely monitoring them, I think it's safer and you're doing everything right and the patient's doing everything right.
Yeah, I think that's well said. Would a patient with moderate to severe myopia, somebody that you can't correct all their myopia, that they're basically still going to have a partial amount when they wake up in the morning, your thoughts about that? Is that those people really benefiting?
Yes, yeah. So I actually have some patients who are okay. I mean, they're just thrilled that they're not a -8. Even if they're -5, -6 corrected, they're really, really excited that they can see better. I do have some that will wear some residual correction, but some of my patients, they tolerate it. 20/30 to them is okay, uncorrected. So I do have a few of those patients. There are now lens designs that do correct for higher amounts of myopia. They're used off label, but with the right design, is that you can target most of the myopia where the daytime uncorrection is tolerable, I think, for most patients.
Okay. I'll finish. No, I think we've completed the questions, but John Reinhardt made a good point. I'm sitting here going, Orthokeratology resources. Yeah, John Montford's book. John's book is still very relevant today, and that was kind of the Bible of orthokeratology. So there are resources. Certainly, the Academy of Orthokeratology for people that are serious about it. International Academy of Orthokeratology and Myopia Control. And their annual meeting, Vision by Design, in April every year is the meeting dedicated to myopia and its management. I know we do a fair amount at the Global Specialty Lens Symposium in January in Las Vegas in that particular area as well, but those are certainly resources to consider. We'll bring tonight's program to an end. I want to thank Dr. Melanie Fregoso for a very good contemporary and clinical look at orthokeratology, and I think we're blessed to have her. I think it's a topic, there's not a lot of people out there that really address it and can address it in the way that she can. And I want to thank all of you for taking time out of your busy schedule to attend. So everybody have a wonderful evening, and we'll see you next month.